I'm going to go through highlights from the uro-oncology year, and officially the title says surgery, but I think that pure surgical trials in urology are a little bit unusual, and mostly they are multidisciplinary trials, and I'm going to go through these 5 highlights. I'm going to start with cancer trials as a general group, and then I'm going to concentrate on the area around the prostate, because I think this is where most of the big news has come this year. And I think what I'd like to do is start with this portfolio of randomized trials. They're not all on here, and I think that UK Urology or Uro-Oncology Incorporated needs to pat itself on the back, because really some of the things that are being done in the UK, either as pure UK trials or as collaborative UK trials, are really world-leading, both in terms of recruitment and design. Things like this. The Stampede study is a fantastic trial. And I put this up, I'm going to come back to it later, just to show you how this is recruiting here. We're up at this activity stage 3 here, with about 2,500 patients in the trial so far, with a target of 3,000. And huge success story. This is another one which has taken a little time to get off the ground, still needs your support. This is the radical study, been divided up into 2 sections. One is the timing the timing study, and the hormone randomization study. You'll see, looking at the number of cases here, that this hormone therapy aspect is up now well above 1,000 patients. This one, which is the timing study, and is a really relevant question, I think. You might think, well, it's not doing too well. It's about 240 patients. This is the largest trial recruitment of this trial, in this type of trial in the world. There are currently 3 trials, one in France, one in Australia, New Zealand, and this. And the French trial and the Tasman trial have recruited under 200 patients. So what's been proposed now with this one is that the data is to be aligned so that there will be a meta-analysis of the radicals timing, of the post-prostatectomy timing question. So it's important that you keep supporting these studies, but congratulations really on what is going to be the largest trial of its type internationally. This one I put up very briefly. This is the CHIP trial of intensity modulated radiotherapy, possibly one of the largest, fastest recruiting trials has ever been. Got up to about 2,500 patients in about 3.5 years, an incredible achievement. And in superficial bladder cancer, the BOXIT study, which is now up to about 220 patients with a target recruitment of about 245. So I think that you can congratulate yourselves on a fantastic achievement. And in the renal area, I've left this one to last because of the topic of the meeting. This is the SOURCE study. And again, you can see from this kind of diagram that the UK has been a fantastic contributor. Some centres abroad, Spain, France, Holland, and so on, and in the Trans-Tasman area. But again, this trial will almost certainly complete its recruitment in the first quarter of 2012. And behind that, there are other trials which are coming down the line. This is the Carmina trial of nephrectomy versus then sunitinib versus sunitinib alone, with a French origin, but with an NCRI badge. And this one, which I think is going to be a really important trial, one which we really should start to consider recruiting to, and the R&D departments are getting mobilized up, randomized trial of nephrectomy followed by sunitinib, or sunitinib followed by nephrectomy in metastatic disease. And again, looking at the pattern of recruitment that we've managed to achieve in the UK, I would be very surprised if we weren't one of the leading recruiting groups in this important study. Now let's move into the area of prostate cancer, because there are a number of new agents and new approaches which really have started to break the ice in areas of this disease: chemotherapy, intracellular androgen blockade, bone-directed therapies, and hormone therapies for high risk. The first one I want to come to is this, which is cabazitaxel in castrate-resistant disease. The TROPIC study, which some of you will have seen, this is the design of the study, is a large randomized multi-center phase 3 trial of cabazitaxel and prednisone versus mitoxantrone and prednisone. And importantly, this is in patients who've already been treated with docetaxel. What you can see is that there's a clear benefit in survival in these pre-treated patients with the chemotherapy. And that improvement seems to be across a number of domains in relation to performance status, whether or not they've had docetaxel beforehand, and in relation to age as well. The downside to this is that there is a higher incidence of febrile neutropenia. It looks bad, but actually most of the worst-case neutropenic patients were in some of the further Eastern European countries where perhaps neutropenia is not treated as well. And when looking at the sub-analysis of the front-line Western countries that had recruited to this, the neutropenic sepsis rate or complications arising therefrom was much lower. So at the moment, this is just going through NICE regulation. It's got its European and American regulatory tickets. Standard first-line chemotherapy, but cabazitaxel is approved for use following docetaxel. What needs to be worked out is where it sits in the abiraterone era, and I'll come back to that presently. The big news, of course, has been intracellular androgen blockade. Abiraterone is the first to market. MDV 3100, which is a competitive androgen receptor blocker. TAC 700 is similar to abiraterone, and there are a number of others coming down the line. So this is the 301 study, which is abiraterone acetate and prednisone versus placebo and prednisone. Now, it's important when considering the side effect profile that when we are looking at these, they're not on nothing. They are actually on prednisone. So bear that in mind when you think about the side effect profile. But what is clear in this group of patients treated with abiraterone acetate is that they have a survival advantage of about 4 months. And that if, again, one looks across the domains, performance status, age, previous chemotherapy and so on, the benefit seems to be across the board. This is an active drug. It is going to be available, and it indeed is available to some of your patients now, and it's something which will be actively discussed in your MDTs. Chemotherapy doesn't seem to affect its efficacy. This is the overall survival after 2 lines of chemotherapy, after 1 line of chemotherapy. It's pretty much the same as in the chemotherapy-naive group of patients. And it is effective against some of the symptoms which these patients get, such as pain. Adverse events are mainly relating to fluid retention. But remember what I said earlier on, that abiraterone acetate versus placebo is not strictly placebo in the truest sense of the word. These patients are on steroids already, and most of the patients in the trial were ECOG performance status 0 and 1. In other words, the fitter end of the market. There weren't any, I don't think, performance status 3 patients, the type that we often see in our wards and clinics. This is going to be followed by the 302 study. This is abiraterone acetate in the chemo-naive group of patients, and this one, if it is positive, will make a big difference to how we treat this disease. It's likely that this, it's already recruited, this trial. It's likely to report probably in the first quarter of next year, possibly the second quarter. My bet is that this is being lined up to report at ASCO 2012. So what about bone-directed therapies? And there are some interesting drugs coming down the line. This is denosumab, which is a monoclonal antibody which is given by subcutaneous injection on a monthly basis. And Amgen, who are the company who have manufactured this, have done a good job, really, in designing very powerful trials. If you look at this randomized controlled trial of nearly 2,000 patients, which compared denosumab to zoledronic acid in men with castrate-resistant metastatic disease in bone. Of course, it didn't affect disease progression or overall survival, but if we look at the skeletal-related events on study, now bear in mind that this is compared to zoledronic acid, not to nothing. Now we know that zoledronic acid had an 11% improvement in skeletal-related events in patients with metastatic bone disease. So this is 17% better than the 11% that the zoledronic acid produced. And if we look at subsequent time to further skeletal-related events in patients on treatment, we can see that the threshold is pushed to the right as you look at it. In other words, that the chance of the patient having a skeletal-related event, a pathological fracture, in their final 6 to 12 months is much reduced with this drug. Again, this is going through NICE regulation. We don't quite know how much it's going to cost. It can be used in patients with renal failure, but the incidence of osteonecrosis of the jaw is slightly higher with denosumab than it is with zoledronic acid. Now, this was the poster girl at the recent ECHO meeting in Sweden. This is the meeting of European meeting of medical and clinical oncologists. There were 16,000 delegates at this meeting, and Chris Parker presented the first results of the alpha-riding study. Now, for those of you that don't know what this is, it's a radionuclide, but it's an alpha emitter. And the importance of that is that the alpha radiation is greater in its strength, and it doesn't travel as far. So it's a more effective agent than things like strontium-99 and radium, rhenium, and so on. This is the study in which alpha-riding was tested. This is the Alsimca trial. And again, it's a well-powered, randomized, multi-center phase 3 trial. And what is gratifying with this study is that those patients, and these were all patients with advanced metastatic prostate cancer treated with the drug versus placebo, there was a significant prolongation of survival with a hazard ratio of 0.69. So quite a substantial increase, and that's better than chemotherapy. And again, if we look at the time to first skeletal-related event, this is pushed out to the right. So again, a very active drug. You're going to hear more of this. It's going to be in your clinics. Now, one that you might not have heard of and won't be in your clinic yet, but is a very exciting development, this is cabozantinib, and this is the publication from ASCO this year. This, again, is a monoclonal antibody, and it's a small molecule inhibitor of c-Met and hepatocyte growth factor. This is a very important axis in prostate cancer. These are treated patients in the waterfall plot. This is looking at the size of measurable lesions in patients with castrate-resistant disease, all pre-treated, and quite dramatic falls off. But I would encourage you to look at the bone scan. This is before, after, before, after, before, after. I've never seen bone scans like this in all my career, where the disease disappears within about 2 months. Now, one might argue that this is an artifact. Something is interfering with the uptake of the radionuclide, but when matched with this and the symptoms, or the drop in symptom scores, this is likely to be a very important drug, provided it's not too toxic or expensive. So let's move on to hormone therapy in high-risk patients. And the 3 areas I want to highlight, PRO7, Stampede, and the Radicals trial once more. Now, big congratulations to the NCRI in the UK and the NCIC in Canada. This was a 1,300-patient study looking at the use of hormones and hormones plus radiotherapy in T3 clinical N0, M0 disease. And this is the design of the study. Many of you will be familiar with this. And following the publication of the SPG7 study, which is a similar design study in Sweden, there was an interim analysis which was presented at ASCO. What this shows is a practice-changing piece of data. These are the patients who had radiotherapy, who had hormones alone, and these are the patients who had hormones and radiotherapy. So there's a clear benefit to patients who've got locally advanced disease to receive radiotherapy with hormones rather than just hormones. No doubt about it. 2 very large randomized phase 3 trials showing that. So that's the standard of care now, that patients with T3 disease get combination treatment. What about radicals, hormone therapy and timing? Again, in the high-risk patients, I mentioned this twice really to keep the foot on the gas. This is the only real trial of its type that's recruiting in the world with numbers of the type that it's got. So we really need to consider this, get it into the MDTs. There is a booklet for the patients, and the important thing, I think, in this study is that the patients receive the information before they have the radical prostatectomy. So when they come back to the clinic and they've got high-risk features, they're expecting possibly to have a discussion about whether they're included. So this trial is flying. It's going to reach its 3,000 mark. This one, we need to watch it because this is the urologists are the gatekeeper for this element of the study. Now I'm going to finish with Stampede because it is such a success story. When it was designed, a lot of people in this country and in Europe and elsewhere said, "You're completely mad. This trial will not fly. The patients won't have it. The clinicians won't be able to recruit to it." And I'm pleased to say they were all wrong because it is possibly one of the leading trials of its type in the world. And that's down to you as recruiters. Just to remind you, hormone therapy versus different combinations of therapy, and the beauty of this is its multi-arm, multi-stage design, which means that synchronously it's possible to test multiple agents over a shorter time period by using this approach, which is to have a pilot study, and this was about 280 patients, to see if it's feasible to recruit, to have a stage 2 where we look at toxicity and failure-free survival with generously placed hazard ratios, so it's easy for the drugs to get through, and then to move on to efficacy phase 4. Now, earlier on this year, the Independent Data Monitoring Committee met to discuss the information relating to the first 2,000 patients. Now, for those of you who've never run a trial before, the IDMC is a group of clinicians and statisticians who meet independent of the trial management group. So, as part of the trial management group, I'm not allowed to see the data, but the IDMC is, and they can then look to see whether the agents are effective, whether they're more toxic, whether one should be stopped. And they considered making changes to Stampede, which was to stop both celecoxib-retaining arms. And we reported this data at the ECHO conference this year, and these are the results from hormone therapy versus celecoxib alone. You can see there's no difference, but I would emphasize the fact that this is in failure-free survival based on PSA. So we don't yet know whether celecoxib versus hormones, celecoxib plus hormones versus hormones alone will have any effect on survival. It may do, and these patients will continue to be followed along. Now, subsequent to this meeting of the IDMC, the Stampede has started to move into its next phase, which is standard therapy has now been that we've got hormones alone, zoledronic acid remains in, docetaxel remains in, and this one remains in. These two continue to be followed up. Following on from that, the next agent goes in as arm G, which is androgen deprivation plus abiraterone acetate for 2 years. And that will run against a new control arm from here on. So this is the beauty of the MAMS design. We can just put new agents in, and the trial management committee is discussing at the moment what else to put in addition to radiotherapy to the prostate, whether it's alpha-ridin, whether it's cabazitaxel, or any of the new agents. So it is an exciting time. I've only scratched the surface of some of the highlights. It's really down to you as recruiters in these trials. It's been a fantastic success. And the UK is now one of the best trial recruiters in the world for a number of urological trials. Thanks.